All right, let's just cut to the chase and kick off this explainer with the one question that literally keeps every med student and resident up at night. What actually separates a passing medical board score from a failing one? Welcome to our high-yield review on skin and soft tissue infections. Today, we're not just reading you a textbook, we are decoding the exact logic that test writers use to trip you up.
So, back to that question. The real secret? It's all about dodging those brutal exam traps by effortlessly distinguishing between clinical presentations that look nearly identical. You know how it is. The boards love to give you a patient with a red, swollen leg, or maybe a blistering rash, and then they toss you 5 answer choices that all sound completely plausible. Well, our goal today is to give you the X-ray vision you need to see right through those distractions.
Here's our game plan for this explainer. First, how anatomy dictates diagnosis. Second, SSS versus TEN. Third, erysipelas versus cellulitis. Fourth, deep danger, necrotizing fasciitis. Fifth, animal bites and odd bugs. And finally, number 6, the gas gangrene traps.
Okay, let's jump right into part 1, anatomy dictates diagnosis, the rule of thumb.
Think of the skin like a giant anatomical puzzle. The absolute depth of the infection straight up hands you the diagnosis. If you're hanging out in the superficial epidermis, you're looking at impetigo or vesicular infections. Drop down into the dermis, boom, that's erysipelas. Hit the subcutaneous tissue, and you've got cellulitis. But once you cross into the fascia, you are officially in necrotizing fasciitis territory. And all the way down in the muscle, you're facing gas gangrene. Visualizing this depth is your ultimate cheat code. If a multiple-choice vignette mentions fascial plane spread, you can instantly cross all those superficial infections right off your list.
Moving on to part 2, our first major battleground, the blistering traps, SSS versus TEN. Now, at a quick glance, both of these cause massive, terrifying skin sloughing, right? But their origins and their targets couldn't be more different. Notice how SSS goes after neonates and kids, and it's driven by a distant Staph aureus infection. That means the blisters themselves are actually sterile. The staph is just hiding out somewhere else, pumping exfoliative toxins into the bloodstream. On the flip side, TN is a severe systemic drug reaction. Think sulfonamides or allopurinol. It's almost exclusively seen in adults, and it carries a really grim mortality rate.
So here is the crucial point you absolutely have to lock in your memory. It all comes down to the exact cleavage level and the mucosal involvement. SSS cleaves super high up, right at the stratum corneum and granular layer. Why? Because its toxin specifically targets desmoglein 1, which is only found in the skin. Because of this, test writers will explicitly use the phrase mucous membrane spared. That is a massive, glaring hint for SSS. TEN, however, rips through the full thickness of the epidermis at the dermal-epidermal junction. And because it's full thickness, the mucous membranes get heavily involved. If the vignette mentions the mouth and lips sloughing off, you better be thinking TEN.
All right, let's head a bit deeper into the skin for part 3, erysipelas versus cellulitis.
Listen, do not let test writers bait you with a generic red swollen leg. You've got to look for the borders. Erysipelas lives way up in the superficial dermis and its lymphatics, and because it's so superficial, you get these incredibly well-defined raised indurated margins. You could literally take a Sharpie and trace the exact edge of the infection. Plus, it's almost always group A strep. Cellulitis, though, that lives much deeper, down in the deeper dermis and subcutaneous fat. Because it's deeper, the inflammation just kind of fades and blends into the normal skin. The margins are ill-defined, and it's usually caused by either Staph aureus or group A strep.
Plunging down to the fascia now for part 4, deep danger, necrotizing fasciitis.
You have got to know the 2 main types here. Type 1 is your polymicrobial mix, aerobes and anaerobes teaming up. You'll usually see this in diabetics or after a GI mucosal breach like Fournier gangrene. This type typically produces gas, which gives you that classic crunchy crepitus when you press on the skin. But here is the massive board trap. Type 2 is caused by group A strep. It presents with absolutely agonizing pain that is totally disproportionate to what you see on the skin, but there is usually no gas in the tissues. So please, whatever you do, do not wait to see gas on an X-ray to sound the surgical alarm.
And that beautifully transitions into the management, which is a strict, no-nonsense, step-by-step protocol. You can't just hang a bag of IV antibiotics and walk away. Surgical exploration and debridement have to happen immediately. It is an absolute emergency. Then and only then do you follow up with a highly specific antibiotic cocktail.
And here is where they'll really try to get you.
Test writers will bait you into picking just penicillin for group A strep. Absolutely not. You must add clindamycin. Think about it. A beta-lactam only kills dividing bacteria by attacking the cell wall. But in a massive necrotizing infection, the bacteria aren't really dividing anymore. They've hit a stationary growth phase and are just sitting there acting like toxic factories, pumping out tissue-destroying enzymes. Clindamycin is a protein synthesis inhibitor. It goes in and completely shuts down that lethal toxin production. Never ever use a beta-lactam alone for this.
Let's shift gears for Part 5, Animal Bites and Odd Bugs.
When you're reading a clinical history, you need to be able to rapid-fire associate the environmental exposure directly to the bug. Cat bite? Boom, Pastorella multicida. Sliced your foot open in a freshwater lake? Aeromonas hydrophila. Got a horribly itchy rash after a weekend in a sketchy hot tub? Pseudomonas aeruginosa. What about a weird skin infection on the hand of a fishmonger or an aquarium worker? That's going to be Erysipelas thrix.
Actually, let's pause on Erysipelas thrix for a second, because this one is pure test writer gold. In the real world, if a resident sees a nasty gram-positive skin infection, their knee-jerk reaction is just to throw vancomycin at it to cover MRSA. But Erysipelas thrix is a gram-positive rod that is routinely, naturally resistant to vancomycin. Finding a gram-positive bug that shrugs off vanco is incredibly rare, which is exactly why you are guaranteed to be tested on it.
And while we're on the topic, you need to have these specific resistance patterns memorized cold so you don't confidently pick the wrong empirical antibiotic. Pastorella is highly resistant to your standard anti-staph penicillins, things like dicloxilin and nafcillin. You've got to use amoxicillin clavulinate instead. Aeromonas, our freshwater friend, is famously resistant to ampicillin. Knowing what not to prescribe is just as crucial as knowing what to prescribe.
Finally, we hit rock bottom at the muscle layer for Part 6, the gas gangrene traps.
Telling these three Clostridium species apart comes down to one thing: spotting the specific clinical trigger in the vignette. See, perfringens is your classic traumatic gas gangrene, a deep ischemic wound contaminated with soil. But it's those other two species where the really high-level board points are scored.
Take C. septicum. It actually has a pretty high oxygen tolerance, which allows it to cause spontaneous gangrene in totally normal, healthy tissue. But it doesn't just happen out of nowhere. If an exam question gives you a patient with spontaneous C. septicum, gangrene, or bacteremia, your immediate next best step in management is to hunt for colon cancer. The bacteria literally leaks out through a tiny microperforation in a malignant colonic tumor, usually right in the cecum.
And then we have the sneakiest one of the bunch, C. sordelii. The classic setup is a young woman post-delivery or post-abortion. It's incredibly tricky because it presents as toxic shock, but they don't look typically septic. The patient will have massive third spacing and extreme edema, leading to severe hemoconcentration. But here's the kicker: there's no fever and no pus. That lack of classic infection signs is exactly what makes it so deadly and so highly testable. By the time it looks like an infection, it's often too late.
So, as we wrap up this explainer, let's circle back to our golden rule. Depth determines the diagnosis. Visualizing that anatomical depth is your absolute best defense against test writer traps. Whether you're comparing the superficial mucosal sparing of SSS against the deep epidermal sloughing of TEN, or checking for the sharp borders of erysipelas versus the deep fade of cellulitis, depth is your North Star.
I'm going to leave you with this final thought to test yourself. A young woman presents in shock post-delivery with massive edema, absolutely no fever, and no pus. If your brain immediately jumped to the C. sordelii trap instead of just generic sepsis, you just gained a huge edge for your boards. Keep visualizing those layers, keep hunting for those very specific clinical clues, and you will crush these exams. Thanks for hanging out with me for this explainer, and good luck out there.